Thank you for this presentation. Good afternoon. Longitudinal evaluation of different part designs in immediately loaded mandibular implants supported overdentures. Dentistry is the start or dates from the old civilization. Mandibular complete denture are often problematic. The decreased retention and stability often lead to reduced function that makes conventional denture frustrating to the patients. The problem is accentuated more by the nature and rates of bone resorption of the mandible. Therefore, restoration of the edentulous mandible with implant-supported overdenture is considered the standard of care. For this treatment modality, the traditional two-stage implant placement with interim relining of the existing denture has been well documented. Although this method provides a stress-free healing period, the first several weeks after implant placement are uncomfortable for the patients, to the extent that functional limitation may continue during the entire implant integration period. To minimize this problem, immediate loading by different attachments was advocated. A recent systematic review and meta-analysis study by Schmel et al. In 2014 compared immediate and early loading to conventional loading of implant-supported overdentures. The authors included only 11 studies that met the inclusion criteria for meta-analysis out of 3,142 identified articles. They found also another 47 prospective reports. The meta-analysis of the 11 studies revealed a statistical tendency to support conventional over immediate loading, while the descriptive analysis of the study, the 47-1, with lower evidence, demonstrated partially contradictory findings. Depending on the number of the implants inserted, the survival range varied from 81 to 100% after 1 year. The tendency was to adapt a primary stability over 65 implant stability cotton or insertion torque over 35 Newton for reports with higher success rate. Therefore, it is wise to assume that any method that would increase the primary stability will favor immediate loading. To satisfy these requirements, several authors tried to use bars to splint the implant. Bar can be supplied with clip attachment, stud attachment, or milled to provide retention through parallel surfaces. When bars are considered over 3 or more implants, they can be completely lock the movement of the denture, but at the same time, they can overload the implant if the implants are short or in linear configuration. When constructing bars over 2 implants, they have variable degrees of resiliency according to the cross-section of the bar used. If the bar cross-section is round, it is termed resilient bar design. If oval, it is termed semi-resilient. And if rectangular, it is termed rigid bar design. It is a matter of controversy. Which type of bar should be used? Or what are the best criteria by bar selection? Increasing implant primary stability and at the same time providing some form of a stress breaking mechanism may be beneficial. A possible way to achieve both goals is to use a resilient bar attachment design. This is the view of the River Nile at the High Dam in Aswan in Egypt. The present study was conducted to evaluate the effect of 3-bar and clip attachment designs on the supporting structures around the implants in mandibular overdenture cases. The 3 tested designs were resilient, semi-resilient, and rigid bar and clip attachment. Study population and protocol. The criteria for patient selection, it could be cooperative patients, free from debilitating systemic disease, good oral hygiene habits, enough bone in the anterior mandible to support dental implant, non-smokers. All these criteria can be obtained according to the patient's history, dental and medical history, lab investigation, clinical examination, either extraoral or intraoral, visual or digital examination. Seeking new denture treatments. 30 patients were selected from the outpatient clinic of the Hospital of the Faculty of Dentistry, Minya University. 18 were male and 12 female. The mean age, 49 plus or minus 5.5 years, completely edentulous with class 1 angle relationship and U-shaped mandibles. 2 implants, 1 piece, were inserted at the canine region of 3.7 millimeter diameter and 13 millimeter length. Immediately loaded with 2 weeks by a bar, randomly allocated in 3 equal groups: rigid, semi-resilient, and resilient bar attachment groups. The study outline was approved by the Research Ethics Committee, Faculty of Dentistry, Minya University. The nature of the study was explained to each patient's limitation, benefits, and side effects. Each patient signed an informed consent. This is one of the selected case at diagnosis stage, showing inflammation as a result of the ill-fitting lower denture. As you see here in the lower ridge. All patients obtained a new denture constructed according to the standard technique. The lower denture was duplicated into transparent acrylic resin stents featuring metallic balls at the implant sites, pre-surgery OBG with the previously constructed acrylic stents, ridge mapping to determine the bone width at the canine region. The radiographic acrylic stent was modified to be act as a surgical stent. Placement of the implant using crystal and releasing incision to reflect the flap, successive drilling to the required diameter. The bone chips from the drill were collected and used to graft the buccal 2 to 3 millimeter threads of the implant when necessary. This is the implants in its place in the osteotomy. And as you see, this is the bony chips collected to be added in the 2 to 3 millimeter around the neck of the implant. 30 Newton torque range were used to seat the implants in its osteotomy and then suturing. Castable bar abutment and fixation screw were selected according to the gingival thickness. Connection of the castable bar abutment during the 2nd week post-implant placement. This is the 3 types of the bar used: resilient, semi-resilient, and rigid one. Adjustment of the bar length intraorally. Adaptation of the bar into channels created in the castable abutment. As you see, this is a channel. fixation of the bar with the abutments by burn-out acrylic resin, metal try-in of the casted bars to see there is enough space between the bar and the gingiva, at least 0.5 millimeter, and the passivity of the bar when put it on the implant. In case of incomplete passive fixation of the bar, it was a split. Then the bar was reassembled with complete passivity by burn-out acrylic resin. After that, fixation of the bar after polishing. Then positioning of the clip attachment over the bar. Blocking out of the space around the bar for clinical picking up. Only the clip was left for fixation to the denture base with monomer-free rebase material. Finally, the denture after clinical picking up of the clip attachments. The patient is recalled to come again for the clinical follow-up and check through the clinical and radiographic evaluation at 2 weeks, 6 and 12 months. Radiographic evaluation were done by using the Longitudinal barreling technique and the Digora software. Clinical examination done through the gingival index, amount of clavicular fluid, periotest values, and patient satisfaction questionnaire. This is the scanned periapical radiograph for the evaluation of the bone loss around the implant by the Digora software. Evaluation of the implant mobility by periotest. Collection of the clavicular fluid by the paper, and then evaluated the amounts of the clavicular fluid by weight. Patient satisfaction done through questionnaire. Each question was scored from 1 to 5. 1 is the weak, 5 is the strong, and evaluated by non-parametric testing. This is the sugar cane farms present in Luxor. My results show the radiographic evaluation. There is a bone loss around the implant showed significantly change with time from 6 months till 12 months. And also there is a significant change between the group. High value appear in the rigid bar, the moderate one in the semi-resilient, and the lowest value appear in the resilient bar. The change of the periotest value during the follow-up period for the right side implants were non-significant, either between the group or regarding the time. The same tendency of the periotest value around the left side of the implants. The change during all the follow-up periods were non-significant, either between the groups or regarding the time. The dot line representing the rigid bar, while the red one representing the flexible one or resilient one, while this solid green line representing the semi-resilient one. For gingival index, the change of the gingiva during the follow-up period were also non-significant, either between the groups in implant site or regarding a time. The red line, again, is the resilient one. The solid blue line is the rigid. The dotted line is the semi-resilient. The same tendency for the clavicular fluids. Show non-significance between the groups, some significant values between the groups and regarding the time. For patient satisfaction the scores of the different variables, either comfort, stability of the mandibular denture, stability of the maxillary denture, retention for both maxillary or mandibular, chewing ability, appearance, and speech. All these variables show non-significant difference either between the groups or regarding the time. All the score ranging between the score 3 or 2. Further follow-up was carried out for 5 years on biannual basis and included bone level change and patient satisfaction. The patient satisfaction scores increased slightly for the 3 groups during the whole period of follow-up with no statistical significance. The bone level change during the second year of the follow-up were essentially the same for the 3 groups, around 0.1 millimeter, and remained unchanged for the whole follow-up period. This is another view in Aswan. This is the Platen Islands. Under the limitation of the current study, it may be concluded that resilient bar design produced less bone resorption than the other 2 designs, which may be due to stress reduction over the implants. On the other studies parameters, the 3 designs have similar influence. Further studies are recommended to reveal if there will be adverse effects on the posterior residual ridge with different bar designs. This is the balloon trip in Luxor. I wish everyone here to come to do it, to see all the pharaonic temples from the top view. Thank you. Any question?
From a dental hygiene perspective, two questions. What kind of oral hygiene aids do you show them to clean under the bar? And do you have your hygienist remove the bars every 6 months or 12 months?
This is a good question. For the hygiene, the bar, we learn the patients how to do the hygiene for the bar, starting with dental floss under the bar and the small brushes, interdental brush to the corners. This part is screwed, as you see. You can easily go to the dentist to remove it and clean it and do all the measurements and then screw it again for the abutments. Yes, yes, I recommend it to do every 6 months. It's much better, as some area it's near to the corners of the bar. The patients can do it enough.